Hello, everyone, and welcome. Before we begin, I'd like to take a moment to respectfully acknowledge the traditional ceded and unceded territories of the Indigenous peoples across Turtle Island, in the land that colonizing peoples now call Canada. We are deeply grateful to live, work, and learn on these lands, which have been cared for by Indigenous peoples for thousands of years. We honor the lasting connection between Indigenous peoples and their traditional territories. We recognize the importance of learning from, respecting, and amplifying the histories, cultures, and contributions of all Indigenous peoples. And we humbly acknowledge the need to work towards restoring meaningful, honorable relationships with them, which includes advocating for the co-creation of culturally safe healthcare systems, the closing of any health gaps between Indigenous and non-Indigenous peoples, and the embedding of Indigenous wellness into all aspects of kidney healthcare. My name is Michelle Lynn Goodfellow, and I'm the Communications and Engagement Manager for the PKD Foundation of Canada, which is the only national organization solely dedicated to fighting PKD through research, awareness, and advocacy, and education and support. Our topic tonight is the mental health journey of PKD, or polycystic kidney disease. We will be leaving time for a live question and answer session after the discussion, so feel free to leave your questions either in the Q&A area or in the chat throughout the presentation, and we'll try to address your questions at the end. This webinar is being recorded and will be available to view on our YouTube channel in the coming weeks, and I've dropped our YouTube link in the chat. I'll now introduce our presenter. Dr. Gavril Hercz has been a nephrologist for nearly 40 years, helping build Humber River Hospital's nephrology program, which now cares for over 600 dialysis patients. Seeing how kidney disease impacts both body and spirit, he trained as a psychoanalyst and developed psychonephrology, an approach that addresses patients' emotional as well as medical needs. He created a transition care unit to support people starting dialysis, focusing on anxiety, depression, and the loss of independence. This innovative program has improved patient well-being, inspired other hospitals, and earned Dr. Hertz the International Psychoanalytical Association's inaugural Community Award in Health. Welcome, Dr. Hertz.
Thank you, Michelle. It's a little bit unnerving to speak to an audience that is out in virtual space, but hopefully we're having a conversation with somebody out there. As well, I welcome your comments and or questions at the end. And Michelle, maybe you can let me know how much time we should leave at the end.
Absolutely. If we have 10 minutes at the end for questions, that's great. If we have more, that's great too.
Yeah, I'll try to leave more because it's nice to have a conversation. So why don't we jump into this topic, which I think is a very important topic. And so let's talk about a typical scenario. And obviously, this is not one specific patient, just for the sake of anonymity, but it's the story of several patients that I encountered over the years. And so we're looking at a middle-aged female who was a pharmacist who, was used to come to the kidney clinic, and then she missed a lot of appointments and unfortunately ended up having an urgent start to dialysis when she ended up in the emergency room. And when you have a conversation with her, she relates the fact that her father had polycystic kidney disease, as she does. He had been on dialysis, had a transplant, but also had many hospitalizations. And as you will see or you experience yourself, many families cope in different unique ways with illness and what that familial illness means in terms of the family. We all try to find some meaning. Was there a curse that was put on our family generations and generations ago? Is it something we did? we all try to find some meaning in terms of what happens. A lot of times, because of the stigma, we may end up actually not talking about it, or we may come from a family culture where these things are not discussed. And so one can imagine that growing up as a child in these kinds of situations, we would experience ourselves a lot of anxiety at an early age when we see something happening with our parents. And if it's not discussed, there's no meaning provided, then we're left as little children to cope with these anxieties and to carry it. And it wouldn't be too surprising then that later on, when we are coping with the illness ourselves, not only is it that we're coping with our current anxieties, but it kind of brings in all those other anxieties that have been hiding in a closet all these decades. And in fact, uh, this patient, when she was younger, she had an issue herself where she ended up in the hospital, and in fact kept it to herself and did not discuss it with anybody, including her family. So you can see that everybody has a unique trajectory of how they try to cope, and that can result in all kinds of complex emotional issues that need an outlet. And the one caveat I'd like to leave you with is that to be a human being, to deal with stress and anxiety is part of the human condition. And there are more helpful ways in terms of trying to cope with it, and some other ways which don't work as well. And those can have a tremendous impact on us. So in terms of this patient's trajectory, everybody thought, wow, it's great. She's a pharmacist. She already knows the language. She's worked in healthcare. She would be great for home dialysis. But in fact, she pushed back against it, and she kept saying, oh, I don't have any space. I don't have room. She really didn't want to bring the treatment home. And I guess this kind of also raises the topic that when we become ill, it's not that we individually uniquely become ill, but our whole family becomes ill. And I think that in a way, I'm probably preaching to the choir when I say this to this audience. I think you would know this more than anybody else. But even when it's not a genetic condition, when any one of us, if your child ends up in the emergency room with a broken arm, you don't go home and say, oh, I feel perfectly great, but my son is crying because he has a broken arm and is in pain. All of us go on a trip when any family member becomes ill, and we all have to cope along with our family members. So this patient goes back to work, and then a way of denying it that, she has an issue, she starts skipping dialysis. And you see that not uncommonly, for example, people who don't take medications. Why? Because if you take a medication, then you have to accept the fact that you're treating an illness. If you don't take the medication, then you don't have anything to treat, you don't have an illness. So there are these different ways that we cope. And one of them is denial, which is an effective coping mechanism. She was reluctant to pursue a transplant. And part of that was that she got settled on dialysis, and the whole idea of switching to transplant, disconnecting from her healthcare team, going to a new team that would look after her was very traumatizing, and that was too much for her. And in a way, it might sound humorous, but you can imagine somebody who's been on dialysis for 10 or 15 years, let's say at Humber, and one day to the next, we tell this patient who knows everybody, everybody knows her, listen, unfortunately, there's a family who's going to adopt you. So you're going to stop living. We're going to stop being your parents in our dialysis clinic. And another family is going to adopt you who will love you just as much as we did. And you're going tomorrow. I mean, I know that this sounds humorous, but imagine how dependent we are on our caregivers, our clinicians, the nurses, the doctors. And from one day to the next, we are basically looked after, and then we have to put our trust in strangers that we haven't met before. And I think in many ways, these are some of the aspects of illness and healthcare that we don't appreciate because we don't see it. It's much easier for clinicians, myself included, doctors, nurses, pharmacists, etc., to see quantifiable abnormalities. What's your blood pressure? What's your hemoglobin? What's your iron? What's your kidney function? The healthcare system focuses on numerical abnormalities, And as long as they feel that they can correct those abnormalities, they feel they've done a good job. And yet then we're left coping with all the emotional turmoil that an illness brings in. And yet it's not appreciated, it's not measured, and therefore it's not talked about. So let's go to the next slide. Okay. So these are just some other examples, and I'm trying to make a point, which I'll come to at the end. Another patient, polycystic kidney disease, started on dialysis. Everybody thought again she would be great on home hemodialysis, but bright lady, ran her own business, couldn't remember any of the instructions from one day to the next. And so what I'm trying to say is that we're not talking about psychiatric conditions. We're not talking about something that, we should send this patient to the psychiatrist, what's going on. We're talking about quote unquote bizarre behavior or turmoil inside us, which causes us, for example, not to remember. We dissociate. We don't want to be exposed to the idea of being on dialysis. I had a patient once who had polycystic kidney disease who was terrified of starting on dialysis. So that's the next patient, for example. She was so terrified that she was wasting away because she had lost her appetite from kidney failure, and yet she refused to start. And I was doing and we were doing therapy. So I would sort of meet with her once a week and just talk about all her anxieties and fears. And I would use the analogy that you're afraid to cross the road because you're afraid you're going to be hit by a car, but yet you're on this side of the street and you have to cross the road to go to the grocery store to buy some food. And yet you're standing on this side, afraid to cross the road, and you're actually starving. And in fact, when she finally agreed to start, she blanked out. It's almost like she fell into a coma. And when she woke up, she said, look, I was so anxious that I had to actually, it's almost like I had to leave my body, and I was looking at myself from above in terms of what the nurses were doing in terms of putting me on dialysis. The anxiety was so large that she kind of almost disconnected from one part of her mind. These are not unusual things. These are coping mechanisms that we all have in terms of managing incredible anxieties that we have. So I don't want to belabor, so I'll go on. And so what happens that in the current manner in which we deal with psychological, emotional issues, they say, well, it's not my area. I'm a nephrologist. I'm a dialysis nurse. It's not my specialty. I think we need to send you to psychiatry. It would be good if that worked, but imagine that even if we say you should go to the social worker, when you have 600 people on dialysis, there's just not enough psychiatrists, social workers to deal with all these issues. The other problem is that the way psychiatrists look at these illnesses, they think of these as diseases. So the way psychiatry appreciates these disturbances is you have anxiety, and that's not a symptom, that's a disease. Now I'm going to label you as having anxiety. And once I label you with the fact that you have anxiety, then there's a prescription of what we use for that. And it's very prescriptive. You need this medication, or you need cognitive behavior therapy. There's no appreciation of the complexity of where that anxiety came from, and how can we begin to understand why this situation, whether it's starting dialysis, having to learn home dialysis, considering having a transplant, receiving the news that your child has PCKD, all these turmoils become medicalized. And the medical model is that there's something biologically wrong, but there isn't. What we're talking about is the human condition. And so the psychiatric perspective does not appreciate distress, that these are adjustment reactions, that these are just the normal spectrum of any one of us responding to incredible stress. Whether it's that, your mother ended up in the hospital with a broken hip, and now, she's distressed. She doesn't know if she'll be able to go home. And now you're dealing with all the tension of what this means in terms of the change in her situation, her condition, the impact on you. So these are just aspects of the human condition. And the more we can appreciate where these disturbances come from, the more we can actually help and intervene. But the thing that I want to say that psychiatry doesn't hold the answer, unfortunately. And the problem is that also in many areas, the clinicians, the nurses, doctors are not attuned to these bizarre behaviors. So they kind of look at it in they look at a logical manner. I don't know why this patient is feeling so anxious when look how well she's doing on dialysis, and pretty soon she'll have a transplant. There's no reason for her to be upset. And yet, look at that, she's so angry and so upset and so depressed. So what happens is that there's no appreciation of the emotional turbulence that illness and treatments can bring. And it creates what's called a cognitive dissonance. We don't understand it. And when we don't understand it, we get anxious. And we don't like that. And so there's a kind of a breakdown in communication, which it'll be interesting to see what your feedback is between clinicians and patients and families. And you see that not infrequently, but there's a code white because the family is in turmoil, they're angry, or people, I don't know what to do with this patient. The patient is swearing, or the patient is abusive. And so there's a lack of understanding the complexity of human behavior and the movement of and the impact of illness and how we move along the illness trajectory. And in that, the clinicians see themselves as being objective. Look, I'm a helpful doctor, I'm a helpful nurse. I don't know why this patient is treating me so poorly, or this patient is swearing at me. They don't appreciate that the impact of their presence and how they communicate with the patient or family can be so powerful in terms of making things better or worse. So the paradigm, or the way psychiatry looks at the condition we're talking about, whether we call it mental health or emotional disturbance. I don't like the word mental health because I kind of feel that that's a psychiatric terminology that perhaps refers to people with schizophrenia, bipolar disorder, etc. Those are psychiatric conditions. What I'm talking about is really an extension of the human condition. The large majority of patients that we see with these disturbances, the disturbances that you feel, is not a psychiatric condition. It's really what it means to be a human being. And so I think a better way to look at this is to look at it through the lens of a traumatic experience. Something dramatic happens. It's as if there's a tidal wave that sweeps over you. There's just too much of what's happening, and you can't keep it stable inside your mind. Right? So somebody could call you and say, okay, we have a transplant kidney. Can you come down to the hospital? So you might say, okay, look, I've been waiting for this so long. I'm okay with this. Next door to you, another patient might get the same phone call, says, oh my God, like, what does this mean in terms of me leaving the hospital that I knew, going to another hospital? Or I wonder what this means that they told me I'm getting a male kidney and I'm a female. Like, is that going to change things, how I feel about myself or how I function? Or, gee, does that mean that somebody who died donates a kidney to me, so somebody had to die? I'm really feeling very guilty about this. And so I'm just trying to expand on the concept that even a simple positive thing, let's say, in terms of getting a kidney transplant, brings all kinds of baggage with it and arouses unique inner experiences in all of us. And the way I might think about it is different from the way, let's say, Michelle might think about it, or another person might process it. And so these reactions are not reproducible, which means that you have to, it behooves all of us to understand the uniqueness of each individual and try to understand why they may have gone on that trip. and everybody's trip is different. So I don't believe in the idea we're all in the same boat. I think we're all in different boats, but perhaps on the same ocean. And so in the process of being traumatized, when something major happens, you start dialysis, you discover that your child has polycystic kidney disease, you have a kidney stone, you hear the news that they may need to remove your kidneys to make room for a transplant. It may become too much to keep contained, and we may end up with panic attacks or anxiety, and our resilience is depleted. We're less able to cope, and a lot of times we feel helpless and hopeless. And the more alone that we are with these news, with these events that we need to process, the more traumatic it is. The more we're connected with a fellow human being who's with us, the more we can be stabilized. The other problem is that not only are we dealing with the current trauma, let's say you have to start dialysis this week, let's say as an example of a traumatic event, but that traumatic event, as I said before, opens up closet doors of earlier traumas that kind of got put away in a closet. Seeing your father start dialysis, seeing your mother have a transplant, seeing your sister ending up in the hospital with some issue. All of these earlier traumas now become incorporated into the current trauma. So you can see how it kind of puts our anxiety off the scale. It just goes overboard because everything kind of gets pushed into one big package. And this kind of too much of something that disturbs everything can disturb our thinking. We can't add two and two together. We can't make plans. We don't know, how do I cook? I used to know how to cook this. Now I can't cook anymore. It disturbs us not only inside, it disturbs our external relationships. We get angry at our spouses. We shout at our children. Everything becomes broken. And the point I want to make that this is all normal. So there's no such thing as this would be a normal reaction to hearing the news about your child having polycystic kidney disease or needing a transplant, and this is the abnormal reaction. It's not like that. It's not like your creatinine is 80 versus 500. This is the normal continuum and a normal reaction. I want to make sure that I normalize these kinds of behaviors as opposed to stigmatizing and say there's something wrong with you. And this just, I kind of made this sort of pictographic, pictorial demonstration of how I think of it. When we get traumatic news, we kind of fall apart. Let's say we're a pot, brand new pot, we fall apart into pieces, and then we have a lot of anxiety. We get panic attacks, dissociation, where I said, I'm not in touch with what's happening around me. And then when we get better, the pieces come together, but we will never go back to the way we were before, where we were a perfect pot. I don't know if that kind of resonates for anybody, but once we know that we're dealing with some illness, that, our fantasy that we would be our life would be riding a Mercedes Benz till the age of 120 on a smooth road, and then discovering that we're in a sort of a jalopy with a flat tire, and now we're going to be riding this jalopy till the end of our days, meaning inside this body that now is dealing with a biological illness. In a way, the cracks will always be there, and sometimes there's more cracks, and sometimes there's less cracks. And when we're in a better place, then we are more reconnected with our families, our friends, and hope comes through. Now we have hope that I think I'm going to try to do this, and I think I can work on this, and there's meaning. I understand where I've come from and where I'm going to, and now I can move on. When everything falls apart, it's like Groundhog Day, the movie. You live in the present moment. Every day you wake up, it's all the same. And it's only when the pieces start coming together that you can begin to move on. So what else is an issue? Not, it's not enough. I mean, I think I spoke about enough issues, but there are more issues, unfortunately. And I'll skip this slide. One other situation is that more and more our medical system looks at patient care and patients as bits and pieces of information, right? So there's the flashing lights of the dialysis machine and how it's working, way more interesting and colorful than that patient who's hiding in the back somewhere. And you can't even go to the patient because there's a computer in front of her, and then there's this big machine, etc. And the flashing lights of the machine are much more attractive and pull our attention away from this elderly patient sort of sitting there in the chair. Similarly, we're more focused on the fistula and how it's working, or we're focused on the potassium or the x-ray. So in a way, it's as if we as patients have become bits and pieces of a machine. And it's as if one of the machines is broken and the doctors, the nurses have to fix the machine. And the idea is, well, as soon as the machine is fixed, you're as good as new. You can go. The other aspect that I want to talk about is that the clinicians look on the left side. You have a disease. There's something wrong with your blood tests, and you have a broken part, and we need to fix that. It's as if they're speaking French, and we appreciate ourselves as having an illness. What does that mean in terms of my inner world? What does that mean in terms of how I see myself at work? Can I continue working? What does it mean in my relationships with my family, with my boss? What does it mean for my future? What does it mean for my family? And it's as if the clinicians are speaking French and we are speaking Spanish. And everybody's asking the other person to speak their language. And then it's no surprise that we get frustrated. And this is like how we get more and more disconnected from our clinicians. This is an ICU full of nurses and doctors, and there's no patients in this building. Why? This is in the United States. The ICU is in another state. And these doctors and nurses are managing the care of ICU patients in another state, not even in the same city, in another state. Because you can imagine if, let's say, you're in a city of 100,000 people and your ICU physician is called out to the emergency room, there's no physician now to look after the ICU. And so basically they connect with a service that looks after their patients. And so this is a trend, unfortunately, in medicine where clinicians are becoming increasingly disconnected from patients. That connection of two human beings connecting is becoming lessened because of all these barriers that I'm talking about. Another barrier is that cyber psychology, just in terms of how we process information and how we are relating to social media, basically our interpersonal connections have become fragmented and disconnected. We are connected with hundreds of more people than our grandparents ever did. But those connections are more and more distant and without us actually being together in the same room. And if you look at any family, even when the whole family is in the same room, everybody's on their iPhone connecting to their own community of 100 people outside. And everybody's sitting together side by side, not communicating with each other, but with their own universe of people that are out there in cyberspace. And in this increasing push to connect with information, with answering emails and texts, we are actually pulled away from our inner lives. We reflect less and less on what's going on inside our minds, our emotional states. We are so much drawn into processing information quicker and quicker, and we spend half our time apologizing why we're so delayed in answering a text or an email, when there's really no expectation that you should answer in 5 minutes. And so, in a way, we are increasingly disconnected from each other, and we don't receive the support that we would have if we sat side by side and communicated with each other. The example I always use is, imagine that, you're in the clinic and you go to Starbucks to get a coffee, and the incredible panic sensation that you feel because you left your phone with your family member, and all of a sudden you're in line for 5 minutes without a phone. What are you going to do now that you have to be alone with yourself? How are you going to cope with your inner self? And sad to say that this is becoming a broader and broader issue in our society. So I just wanted to sort of draw your attention to what can happen when there are changes. This is, for example, when somebody starts dialysis, but this can happen in any traumatic situation. You can see how as trauma hits, you can become increasingly depressed, a phenomenon which may last for three to 6 months. And you can see that the change in your mental state can be significant enough that it increases the risk of hospitalization and illness. So when we talk about these emotional turbulences, they are significant not only in terms of how you're coping within yourself and with your family members, but it's impactful also in terms of your physical health. And that's why any attempts that you make in terms of bettering your inner self is very important in terms of your health. Same thing, how anxiety goes up and then it comes down. The important thing I want to talk about here is how when you have social support, you don't go down as much. So the line on the top in each example is if you appreciate that you have social support, husband, wife, parents, etc., you do much better and you don't go down as much in terms of anxiety and depression. And in a way, you're actually more resilient. And the other way to look at it, if you're more resilient and you're able to maintain your resiliency, you're less likely to dip into anxiety and depression. This may look like a confusing slide, but I'll just spend 2 minutes on it just to show you how powerful some of these things are. These are people who come very, very sick to the emergency room, and they end up in the intensive care unit. And because they were so sick, they had a life-threatening illness, they ended up in the ICU. A fair number end up with post-traumatic stress, right? So they are better physically, they can go home, but they just have ongoing anxiety. And you can see on the horizontal axis that if the patients initially admit that they had more emotional support, that they felt that they got more compassion in the emergency room. So the higher the number on the x-axis, you can see that their chance of having post-traumatic stress is much lower. If they say that they had very little compassionate care in the emergency room, then their chance of having post-traumatic stress after they go home from the ICU is much, much higher. Just one example of showing how powerful empathetic care can be. And we can talk about it. The other thing I wanted to sort of normalize is how whenever you have a traumatic event, basically your mind stops functioning. Whenever we're anxious or depressed, our memory is very poor. So it's always helpful in these situations to go with somebody to the clinic, because you will only remember a small part of what the nurses or the doctors may tell you. And you say, I don't remember any of that. And just important to keep in mind that that's also normal. When we're anxious or depressed, we don't remember anything. And again, Michelle commented on transition care unit. So I don't want to belabor that, but just that there are systems that can be created in hospitals, clinics, etc., where focusing on providing more compassionate care can be very helpful for patients. And I would advocate that your society, your organization, basically, beat the drum, that you should advocate for more compassionate care wherever you encounter the healthcare system or in any venue, because that will provide grounding and diminution of the disturbances that you may feel. And again, I'm sort of getting to the closing slides, but there will be time for comments and questions. So patients, families who are in distress, what they really want is empathy. And people would say, oh, but providing empathy takes so long. We don't have time. We have so many patients in the clinic. I'll give you an easy example. You come to you come to the clinic in the hospital or where you go, and a lot of people are waiting, and you get to the secretary who says, Mrs. Smith, can't you see how busy you are? Take a seat and wait for your turn. 4 seconds. Busy clinic, same secretary. Next day said, oh, Mrs. Smith, so nice to see you. Look, I'm really sorry, but we're really running behind a bit because it's such a big clinic. But we're going to get to you, but please have a seat, and I know you're here. Same 4 or 5 seconds. The way that it's delivered is so different. I mean, you feel so different when somebody sort of dismisses you on top of being anxious to start with, versus somebody who acknowledges where you're at, what you're experiencing, and says, listen, we're having a lot of difficulties, but please have a seat. We'll get to you. Wow, poor people, they're really busy. What a difficult clinic. It's not about time. It's about how we connect. They did a study with surgeons asking patients. When the surgeon stood for 5 seconds at the foot of the bed, said, oh, Mrs. Smith, your surgery went well, you can go home. Oh, what a dismissive surgeon. He totally doesn't communicate. I can't believe this guy just came in and left. Same surgeon sat down for 5 seconds, sat down, eye level, and said to the patient, oh, Mrs. Smith, you did really well, but you can go home later on today. Wow, he spent so much time with me. He was so caring. What a great surgeon. It's about not the quantity of the connection, not about the time, it's the quality of the connection. And again, within the kind of system that we are in, sometimes it's hard to see the importance of these things. And it's only when you've been personally in that area or involved in that situation, you realize, I realize now how important these things are. And it's about what I try to encourage with the nurses is have a conversation with the patient, treat the patient as a fellow human being. And I know you will have done that if you can tell me something insignificant about them. So in the transition care unit, I would tell the nurses, make sure you document something insignificant every time you see the patient. Oh, the patient had their birthday party this weekend, and their dog ran away, and their son came, and they got this really nice present. Great. So that means you had a conversation with the patient that was like one-on-one. You treated each other as a fellow human being. It sounds insignificant, and we say, oh, you're wasting your time. Very, very powerful in terms of grounding us and making us feel more secure. I want to really advocate, and I don't know, you must already have this peer support. There's nothing more powerful than seeing somebody else who's going through the same situation, who's gone through it, has moved on, or has experienced the same thing. And you realize that this person is going through the same thing, has gone through it, and understands what I'm going through. That is probably one of the most grounding things that can be kind of worked upon in sort of bringing that kind of connection to these kinds of groups. Very important. So in terms of, I'm getting to some summary slides. I think it's important to appreciate that patients feel vulnerable very often. And I also do psychotherapy. Many of the patients I've done psychotherapy tend to be patients with polycystic kidney disease. Again, because there's so much early trauma in terms of family members and current traumas. There's so many complex issues that it's not unusual for people to need psychotherapy. And I think it's important to normalize that and say, there's nothing shameful about that. This is what it means to be human. And it's also important to accept the fact that we can have this bizarre behavior come out of nowhere. Some of you say, well, you're doing so well, you feel so good, you look good, you gain weight. What's the problem? And you say, well, I'm falling apart with anxiety. The flip side is there could have been some major medical illness surmounted, and you're doing emotionally amazingly well. And that's just as confusing to the nurse or the doctor. They say, well, if I was in your shoes, I think I would be much more anxious. And he said, no, I'm doing well, doctor. I have a lot of supports. So either way, there's a disconnect between what's happening physically and what's happening emotionally. And that's normal too. They don't go hand in foot. No, not that's not. Uh, they don't go. They don't go hand in hand together, but they're disconnected. And again, I think it's important to appreciate that it's normal for this disconnection to happen. And and I want to put in a plug again for peer support and how important that is in terms of providing some meaning in terms of what we're going through. The last aspect that I want to focus on is that I have and Michelle asked me to sort of put some of these slides in. I have a social media presence. Again, in as much as I was bad-mouthing psychology, it is a useful way to disseminate information and provide support. And so there's a website which has talks about different aspects of emotional turmoil, social turmoil, issues about starting dialysis, and I have a blog site, and the blog is posted every Friday evening. Actually, we have some video interviews with patients and family members with polycystic kidney disease. They're actually posted. I should bring it forward. When it was, there used to be, I don't know if they still have it, there was an annual polycystic kidney disease meeting every year in Toronto with Dr. Pei. And a couple of times I had a session with a patient that was videotaped. So that's also on, and I think you might find that interesting. What I want to point out is that we have all these blogs that we post every week. Some of them are videos. For example, there's a top left, a patient who was an altruistic donor and in London, England, and there was an interview with her. There's one, for example, where they looked at what's the most soothing music in terms of anxiety. So there's a lot of different topics that we post on, so you might find it helpful. And I also have a brochure that I wrote in terms of how to cope with anxiety and worry. And you can download it and copy it. And it has some helpful coping techniques that I think Michelle asked me to sort of provide some of those pointers. And the other important thing is, and it's very important, I think, in Toronto, that I have a widget which translates the whole website into any language of your choosing. So in this, in our multicultural, multi-ethnic community that we live in, we have many patients who don't necessarily speak English. So what you can do is pick your own language, and the whole website, including all the blogs, will be translated to that language, making it accessible. And this is just an example, let's say on the English on the left, and then you pick French and translates everything into French, let's say. So, or any language of your choosing. We're also on Instagram, TikTok, YouTube, etc. So feel free to access. What I would recommend doing is go to the bottom, and where it says subscribe, just put in your name and email, and you'll automatically be subscribed, and you'll get it. And you can, after a while, if you get bored, not interested, you can opt out. And if you want to put your camera on your iPhone to that logo, that'll take you to the website at this time. I'll leave it on for a minute before concluding. But this will be a good way to sort of get the blogs. And also you're welcome to provide comments or questions, which I will answer. And I think, sorry. There were some other sort of useful techniques that, I was just sort of at the last minute scrolling some, these are sort of CBT, cognitive behavioral therapy techniques for dealing with extreme anxiety and panic attacks. Talking about, well, this disaster I'm thinking about, is this likely to happen? Yes, no. If not, then do you need to worry about it? Yes, no. So it's kind of like restructuring. And for example, journaling is very important. Any way that we can find to process these free-floating anxieties into something like words, either writing it down or speaking to a therapist, will lower the intensity of the anxiety. If we don't manage it, then the anxiety will either stay in our feeling state or it goes into our bodies, because that energy has to go somewhere. So we get migraine attacks, we get back pain, we get asthma, we get hives, we get itchy. So the anxiety has to go somewhere. Either we feel it or it goes into our bodies. If you can put it into words, if you can speak to somebody about it, then you diffuse the tension, you diffuse the energy. There's mindfulness, there's UCLA, I just put that, if you look up like UCLA mindfulness, they have a free guided meditations that you can listen to, and that's very helpful as well. So I think I'm going to stop now and maybe leave time for questions and comments. So maybe I should stop sharing. Okay, great.
Great. Well, thank you so much for that portion of the presentation, Dr. Hertz. We really appreciate it. We do have time for some questions, so if anyone would like to ask a question, they can put that in the Q&A area or in the chat, whatever feels easiest to them. I see we have a question right away, and someone's saying, any advice to a person diagnosed with PKD, though no symptoms of reduced kidney function at the moment? So someone who's got PKD, their health seems to be pretty good, but they probably have some anxiety and uncertainty due to the fact that they maybe don't know what's going to happen and when it's going to happen.
Right. So I think that, it's a good question because it's the unknown. The unknown is always can always bring on anxiety. And so I think that in a way being able, I think that's your society in a way providing information and providing peer information is powerful, and a lot of patients now go to sites, patient sites where other patients can post their experiences, and then they realize, what, I am part of I'm not alone. When we feel alone, the anxiety goes through the roof. It's when we feel secure with other people that we can then begin to learn and explore. And the analogy I always use is, imagine when you drop off your child in the nursery school. They go berserk. They start like screaming for you, and they become very anxious, and they're crying and screaming. That child is sitting on the floor paralyzed. The minute the child begins to feel secure, the child, he or she, begins to crawl on the floor, connects with other kids, starts discovering and learning. So the road to discovering and learning is about feeling secure. And so what I would say in this situation is try to find something that will make you feel secure, which is connecting with another human being, connecting with family member, connecting, if you can, with your clinicians. And at that point, when you feel connected and your anxiety lowers, then you can actually fuel that and make it better, because now you can collect information, say, okay, I know that here are the things I need to focus on, and I know that I have a certain sense of my trajectory, and I think I will be okay.
And I see there has been something in the comments. Teresa is saying, I'm 12 years post-transplant today. Congratulations, Teresa, on your new kidney birthday. I was coping and doing okay, fighting anxiety and depression, but ended up off work a year and a half ago. I feel like I broke and finally asked for help. Do the medications cause some of this, like prednisone or tacrolimus? I was also on my Fortic, but they've stopped that due to skin cancer. So I guess her question is, does some of the medications that you take after transplant, can they contribute to things like anxiety and depression?
So I guess the first caveat is, we don't deal with transplants at Humber, so I don't want to put myself forward as an expert in this. The only thing I know is, prednisone, and especially not probably the doses used in late transplant, but high doses of prednisone can result in psychiatric illness, tremendous anxiety, insomnia, depression. And so that's as far as I can take it in terms of finding some external cause. And the difficulty, I think, when it comes to emotional turbulence is that we tend to kind of focus on the outside first, right? We say, we don't say, what, I have an inner world, It's very complicated, like everybody else's. And at this moment, it decided to manifest itself with these emotional states like anxiety. We try to find, because we can't live with the unknown of where did this come from. So what we do is we try to find some outside cause. You know, my husband is not taking the garbage out. No wonder I'm feeling anxious and stressed. My child is not doing his homework. No wonder I'm feeling stressed. Um, you know, and so we always start with the outside, and the assumption is that we're perfectly well inside, but it's just something outside. I think it's best if we start that these things always start from the inside. And when we're in a better place, our child not doing their homework is like, okay, let's see what we can do. On the other hand, when we have a lot of disturbance inside, it's like our tolerance narrows and we lose it so much easier. Our buttons get pushed so much easier. And so I think the more we can appreciate that, you know what, here I go again. I've fallen into this anxious state. And my pattern is that I'm going to get angry, or I'm going to withdraw, or whatever. I'm going to start getting headaches. The more we can appreciate that this is our pattern. And we all have our unique patterns of how we respond to stress. And the more we can kind of figure it out and say, this is me, this is how I react, the more we can kind of compartmentalize and say, oh, here I go again. But I'll be okay because before I went on this trip and I was okay after.
I see a question in the Q&A section. Lori is asking why clinicians don't always provide support for people with anxiety. Are there any strategies to support clinicians?
How much time do we have? You know, I do a lot of speaking, and I try to push this topic. And increasingly, I'm finding that, you know, the culture of healthcare, the culture of hospital systems is processing too many patients, too much information to have bandwidth for this. And in a way, the patients are saying, I would like some attention to this, and either it's not seen, or, you know, sometimes the clinicians themselves become anxious. So if there's this fear that, you know, if I'm going to sit down here, I'm going to start listening to your issues. Number one, I'm the kind of clinician that likes to solve a problem. I give you a prescription, the problem is solved. How am I going to be able to solve this problem that you're bringing to me about what kind of issues you're dealing with emotionally? I don't have the time for this, and I can't wrap it up. But the important thing is that that's why therapy is so powerful, because you spend, let's say, an hour with a patient, the therapy continues even when the patient leaves the therapist. It's not like you're only having treatment when you're with somebody. When you leave the therapist, your mind continues that conversation, and that feeling of support. And so it's very powerful connecting with another fellow human being. But we kind of minimize it, and we almost look at it as, well, that you're wasting your time. After all the information is in the computer. So I think it's about, as a society, PKD society, to push for this kind of care and attention to this. And I think numerically, you know, you're powerful, and I think you just have to push this. And, you know, the ORN is trying in terms of making mental health more increasingly a priority. So I think that certain groups are listening. The medical students are coming into the hospital systems are way more attuned now than the generation before. And I'm hoping that things will change, because the culture of these young residents become part of the fabric of the hospital system will change for the better.
Thank you. I see two comments, one in the chat and one in the Q&A, that both deal with if you're the partner or a family member or caregiver of someone with PKD, are there any peer resources that there might be, or any recommendations that for caregivers of people affected by PKD?
So that I think, Michelle, you probably would know that better than myself. So I don't want to sort of speak to it. But the only point I want to make is that it is important. And at times, it's almost more important to treat the caregivers than the patient themselves. Because you see the caregivers coming in, they've taken the whole burden on themselves and they're burning out. And you need to support the caregiver because they are the foundation for the patient. And and I think a lot of times we tend to overlook that. And you see that very commonly where the caregivers are doing well until their their husband, sister, etc., does well. The minute that caregiver doesn't have to provide that intense care, they fall apart. All of a sudden now they get pneumonia or they get arthritis. It's as if there was no room for their own issue and illness. And now that there is, things come up. So I think it's very important, but I don't know if Michelle, you wanted to comment on that.
I can say a little. People may be aware that we at the PKD Foundation of Canada offer a monthly peer support for both patients and caregivers of people going through or approaching kidney failure. And we're also, genuinely interested in expanding the kinds of peer support meetings that we have to different groups of people, whether there's someone who's newly diagnosed or perhaps for caregivers. So if that is something that really appeals to anyone who's listening, by all means, let us know and we'll try and accommodate that. The Kidney Foundation of Canada also offers peer support, and I believe they have a monthly meeting for caregivers. And I'll be sending out an email tomorrow to follow up on this presentation, and I can include some of those links. If people haven't thought about those before, you may find that really helpful. We also have, the PKD Foundation has a private online community just for our PKD community. And it's a chance for people to make a virtual connection. It may not be the same as that physical connection you were talking about, Dr. Hertz, but I know a few people who have really found meaningful friendships there with people who are going through the same thing that they're going through. And so that's another place right now that we have to offer for people to connect with others. Yeah, so that's what I can say about that right now. We have a couple more questions, and I just want to check with you, Dr. Hertz. Are you okay to go a little bit over time just to finish these up? Okay. We have someone asking, who would be a good person to see about depression and anxiety when things are getting worse and you've had to quit working? I don't have money for private counseling, and I'm also in Alberta.
So I think you have to look at, so I don't want to kind of conclude by saying that I'm disparaging psychiatry. So certainly when the anxiety or depression is tremendous, then there is a need for medications and education in terms of CBT, which can be very effective to kind of bring the intensity of the emotions down enough that you can actually have a conversation with somebody. So the kind of therapy that I was alluding to or that I do, it doesn't really work for somebody who's having panic attacks. You need to be kind of brought down to a place where you can begin to have a conversation. So I think one is would be to access psychiatric care, which is, it's covered by health, by provincial healthcare. So that would be a start. And, many of the social workers in these areas, in the renal clinics, et cetera, some of them are actually practicing psychotherapy. So they are cognizant. And then, so you have to look at the resources that are available in the community. And I think you'd be surprised how many resources there are. Like mental health issues are increasingly being recognized and being addressed. The problem is it's almost like we're disconnected from it. And so the resources are there, but we don't know what's out there. And so part of it is you have to hunt for it or connect with a social worker, etc., who can sort of guide you in terms of what's available in the community. And it's not all that you have to pay for it. A lot of it is available in the community, but it's almost like you have to start on the road of where to find the information. It's much easier to say, I have a heart problem, I need a cardiologist. It's straightforward. It's a much more confusing world when it comes to emotional issues, because there's so many people who are helping in this area, and it's not clearly defined as one professional individual.
There were a couple of comments in the comments, mostly thanking you, Dr. Hertz. Stephanie saying, thank you. I've been the primary caregiver to two close family members as they went through dialysis and transplant. In both cases, mental health was not a priority and not taken into consideration. I'm so grateful that you are talking about this and making mental health an important aspect of care for PKD patients. So wonderful thought there. And someone else, Krista, is saying she advocates for the PKD forum, the My PKD that I was talking about a little earlier. She met someone in the exact same stage as her, and we've become an excellent support for each other as we navigate stage 5. So that's someone letting you know about My PKD. Now I see in the question and answer section, Sandy is saying, I tremendously appreciate this presentation, and we can be more aware of what we need within our own community. Is this information offered to the ER nephrologists as we're on the receiving end of their care? Thank you. I think that's similar to the question earlier about our caregivers, physicians receiving this kind of training to take the mental into account.
Again, I think that I think they're receiving it in medical school. I'm not sure how much of it has permeated into the hospital system, because it's sort of it's a hierarchical education process. So it depends on the residents and the fellows interacting with senior members, let's say, of the nephrology program, and to what extent they are sensitized to this. And obviously then they mentor in that manner. So I think it can vary, but I'm hoping that with the generational movement, there'll be a more and more appreciation of this. And I think that there's a need for advocacy. Like, I think there's an onus on all of us to kind of work on this psychosocial culture that we're all immersed in. And the other caveat I would say, as we get older, I think we become more and more empathetic, because we all realize that we're all facing our own personal challenges, as opposed to I'm on this side of the divide and you're on the other side of the divide.
Someone in the Q&A was just saying, thank you for the recommendations on help. I never thought about a social worker, and I have free access to one. So I will add as well that most social workers, whether they're tied to a kidney clinic or to a primary care physician, can be great connectors of information. So they know what's available locally, and that they can often direct you somewhere else if you need some help. And I see one more comment from Keith. He's saying, I've been in kidney failure with PKD since early this year, and I was put on dialysis. Then I got an infection, so the idea of transplant was put on hold until my numbers came up to where I would survive the surgery. I found this stress overwhelming, and I thought I would have to turn down my live donor as I was so ill. Today, I found out my numbers have improved and I've been approved for transplant. I'm elated, of course, but it's very difficult to process all the feelings I have. Going from extreme stress to extreme happiness is an example. Any suggestions for someone experiencing that range of emotions?
No, I mean, so congratulations. I think that's great. But you're right. I mean, and you present a very interesting topic where it's fantastic news, and people are probably saying, "What's the matter with you? Why can't you be happy after getting these?" Right? So there's a disconnect between what you're feeling inside and how the world is reacting to you. It's almost like you feel like a stranger, and this pressure of an expectation of how you should be feeling when you're not feeling that. I think one thing is to say that, we are all resilient and we don't stay at the same place. So, slowly things will change and things will improve. So that's one caveat, that, there's ebbs and flows to life. We don't stay in the same place. The more you can either recognize where you're at and let's say be able to talk to somebody about it, I think the better you will feel. That's one aspect. And the other aspect is to normalize it, that what you're going through is absolutely normal, as opposed to, oh, not you have something bizarre going inside your emotional state or your mind, and you have an illness, or you need something, something to be done to how you're feeling. What you're experiencing is absolutely normal. This is what being alive means. And being in the midst of a disturbance is normal. But you're right, you want to be able to kind of get to a better place. And I think the more you can communicate it with somebody who's willing to listen to you, and it's not like they need to come up with a solution. Here's what you should do. Take 2 Tylenols, you'll feel better. It's really about just somebody listening to you and just putting all that turmoil and thoughts into words. And the minute you can do that, I think it also helps.
Great. Well, thank you everyone for your questions and your comments. We've been so lucky to be able to have Dr. Hercz tonight to talk to us all about this topic. I see some thanks there in the comments from Keith. I just want to reassure everybody that I will be sending out an email tomorrow with some of the links and resources that Dr. Hercz has talked about. And when this presentation has been uploaded to our YouTube channel, I'll also send out a message to everyone who's registered. And I hope that you enjoy exploring some of the resources that Dr. Hercz has on his website and in his materials. And I'm just so glad that we have nephrologists like you, Dr. Hercz, who have seen a gap in the care and have been working to address that. Thank you so much for being here tonight.
Thank you. Feel free to connect, and I'm happy to try to answer your questions in the future.
All right, and more thanks I can see coming up in the comments. Thank you, everyone, and I'll be ending the webinar shortly.